And insomnia at times is a label that we use, but where we go wrong is that when a patient comes in and say they have insomnia, in the mind of a less trained professional, they're going to go, oh, you have a diagnosis of insomnia. My triggered reaction is give you an Ambien or Trazodone or something. But in actual fact, in the head of the provider, we have to figure out, is insomnia a symptom of something else? Or is it the actual disease itself? Is that a diagnosis? And for you to actually have a diagnosis of insomnia, you need to rule out so many other things. And that's why the evaluation comes in as well, is not to jump to conclusion, because the patient has a layman's way of describing things. And the practitioner's head, they need to reinterpret that to figure out and how that makes sense in this whole scheme of things, and not just to jump. Because think about it, you're there to see a primary care provider. It's a 10-minute visit. You're talking about your diabetes or your weight loss, your high blood pressure. You're talking about the headaches that you may have. And then, oh, doc, I don't sleep well at night. The insomnia, I tried Benadryl. Okay, here, try Ambien. I'll see you back in 3 months. And that's what the discussions are right nowadays. So, that's why before I thought on the treatment pathways about sleep apnea, I just kind of want to broaden it to say that, some people think they have narcolepsy. It is worth, some patient come to me and says, I have narcolepsy. I was like, how do you know? Oh, I was told. I was like, how do you know? Because there is certain strict criteria to rule someone as as narcolepsy, and requires in-lab study and multi MSLT, which is multiple sleep latency testing. I fall asleep all the time.